Hi. That's why you just have to. It already says this session is being recorded.
I just started it. Okay,
Okay.
everybody. So today we're going to talk about the management of lymphedema. This presentation, we're trying to overview the anatomy and physiology of the lymphatic system. We'll go through diagnosis and differential diagnosis of lymphedema and lymphedema and its treatment. So the lymphatic system serves important immunological and drainage functions. And there's many different vessels and organs that do this. We have the superficial lymph vessels that are pictured here and are responsible for draining the extracellular fluid in the body. This fluid is coming from the skin and the subcutaneous regions of the body. The course of the collectors is interrupted by intervening lymph nodes. So you can see here on the diagram, you have lymph nodes in certain areas, and the fluid comes into these areas, and the lymph nodes will concentrate the fluid and also expose the fluid to lymphocytes, which will then make it more concentrated and allow it to go further to be transported. The other organs that are listed here have more immune function rather than drainage function. So the spleen is the largest organ of the body, largest lymphatic organ of the body. It exposes large amounts of blood to lymphocytes within the spleen, which then triggers the immune response when foreign material is present. The thymus gland is a lymphatic organ which serves as a site for maturation of immature lymphocytes, which upon leaving the thymus assumes responsibility for the cell-mediated immune response. Peyer's patches are a collection of lymphatic tissue located in the lower ileum, and the lymphocytes are white blood cells critical for immune function. So what is the purpose of the lymphatic system? The first thing it does is it transports water, protein, and large molecules from the interstitium to the cardiovascular system. Next, it's going to absorb fat and fat-soluble vitamins through the intestine. So this fluid is called chyle, and we'll talk about that later on. And the last thing it does is it serves the immunological function. So let's talk about the different layers of the lymphatic system. So the lymphatic system, most of the drainage occurs through the skin, which is the largest organ of our body. And here you can see in the picture that you have many different layers under the skin, which is where the lymphatic system is housing. So you have capillaries, precollectors, and collectors that are situated in the skin and the subcutaneous tissue. And these lymphatics are responsible for absorption of extracellular fluid, while the larger collectors and the trunks are there for transporting the fluid. So here the blood vessels and the capillaries are shown in red and blue, and the lymph vessels and the capillaries are shown in green. Are you, Victoria, I just want to check in. Are you able to hear me okay?
We are struggling to hear you, but we are following it.
Okay. Okay, so this picture is showing the drainage pattern of the superficial lymphatic collectors, which eventually converge in the axillary and inguinal lymph nodes. So as you can see here, there's a pattern of drainage. So you can see the lymph vessels are coming down and they drain into the lymph nodes in the inguinal region, and from the leg they're coming up and draining into the inguinal region. In the arm, they're coming up into the axilla and draining into those lymph nodes. And these vessels are coming up through the arm and draining into the lymph nodes. You have the same pattern happening in the back. And then all these lines that you see, these white dotted areas, those are called watershed areas. And what that means is those areas are where the vessels change direction. So if you look at this middle line here, these vessels are coming this way and these vessels are coming this way. So there's an area where the direction changes, and that's gonna be important later when we do our manual lymph drainage, because we're gonna try to help change that direction to get the fluid to flow where we want it to go. Okay?
Yes.
Okay, so now we'll talk about the collectors. So the collectors are slightly deeper, and these collectors have something called the lymphangion. And the lymphangion consists of the collector has many lymphangions in them. It's like a small functional unit in the collector, which has the ability to contract. And that's how it transports fluid from distal to proximal. So there's an intrinsic contraction in the collector, and that's stimulated by the sympathetic nervous system. The average rate of the contraction is about 6 or 10 times per minute. And during this time, it will, in the largest vessel, which is the thoracic duct, it will transport 2 to 2.5 liters per day of fluid. So if we look at this picture, this is a picture of the superficial lymphatic collectors that transport fluid. So if we go from the bottom, you'll see here we have the right lumbar trunk and the left lumbar trunk. Those are coming off of the inguinal region, and they're going to join together, and they're going to join at a point called the cisterna chyli. That's right here, and it's about the level of L2 in the body. And then from here, the fluid is going to go up the largest vessel, which is called the thoracic duct. And that runs along your spine. And then it comes up and it joins into the left subclavian vein. So 3/4 of our body's fluid goes into the left subclavian vein. And then the right side, the right upper quadrant goes into the right subclavian vein. So the purpose, like I mentioned earlier, of the lymphatic system is to transport fluid from the body back into the venous system. So these are your veins. So the extra fluid that your body's collected is going to go back into the lymphatic system, or back into the blood circulation. So when we talk about the cisterna chyli, that's where all the vitamins and the fat-soluble vitamins that were absorbed in the abdomen, so this area, this fluid is going to be whiter than the rest of the body if you were to look at the lymphatic fluid. And that whitish appearance is called chyle. Okay, so next we'll talk about the lymphatic trunks. So this is where I was talking about the lymphatics come and join back into the venous system. And you'll see here that you have your your thoracic duct. Number 1 is the thoracic duct. It's going to go behind the venous angle, and it's going to come and join into the left subclavian vein. On the right side, you have your right lymphatic duct, and it's going into the right subclavian vein. Okay?
Mm-hmm.
So this is important because when we start doing our manual lymph drainage, we always want to start by clearing the area above our clavicle, which is right up over your clavicle in your neck. And the reason we do this is because we want to clear this area first, these two areas of any buildup or fluid backlog, so that because everything that we clear from our body is going into this area. So that's why these two areas are very important to clear first. Okay, so this is just a diagram. It's an X-ray of the right pelvic region, and it shows the inguinal lymph nodes and the lymph collectors, and they show this through lymphography. Okay, so let's talk about filtration. So the most important process of cell nourishment is diffusion. However, filtration and reabsorption processes at the blood capillary wall are important in lymph formation. So according to Starling's hypothesis, most fluid that leaves the blood capillary through filtration will be reabsorbed back into the bloodstream. So it's coming out here, but it's going back on the venous side. It's getting reabsorbed into the bloodstream again. But only a small percentage will escape into the extracellular fluid, and that's what we call lymph fluid. So that's according to Starling's law. So Starling's equilibrium says, under normal conditions, a state of near equilibrium exists at the capillary. That is, the amount of fluid filtering outward from the arterial ends of the capillary equals almost exactly the fluid returned to the circulation by absorption. The slight disequilibrium that does occur accounts for the small amount of fluid that is eventually returned by way of lymphatics. It is already clear that the lymphatic system functions as an overflow mechanism to return to the circulation proteins and excess fluid from the tissue spaces. So going back to this, you can see this is your yellow cell is your interstitium, and the fluid that comes out, some of it escapes and becomes lymph fluid, and that's where the lymphatic collectors are collecting that fluid and transporting it deeper in the body. So let's talk about what can happen that can cause edema in the body. So we can get increased capillary hydrostatic pressure. So increased pressure in the capillary will increase the fluid in the cells. You can have decreased plasma protein. You can have increased capillary permeability, meaning more filtration. Or you can have a blockage of the lymphatic return, which is lymphedema. Anything that disturbs the balance of forces within or outside of the blood capillary may create edema. So there's many types of edema, and we need to figure out which type we're looking at. So what is lymphedema? Lymphedema is an abnormal accumulation of fluid, of protein-rich fluid in the interstitium, which usually causes chronic inflammation and reactive fibrosis. So when there's a mechanical failure of the lymph system, that's when your protein-rich fluid is accumulated in the tissues. And it usually then causes something called fibrosis or buildup of connective tissue. So here's a picture that you can see from the picture that the lady has lymphedema in her left upper extremity. So the usual signs and symptoms we have for lymphedema, it's a slowly progressive swelling, and it's increasingly more protein-rich fluid in the interstitium due to a failure in the lymphatic system. There is usually pitting early on, and then later there might be less pitting, but more of a hardening or a fibrotic change to the tissue. And you can use what's called Stemmer's sign, which we'll go over when we come in class, but basically you're unable to lift the skin off of the toe. That's a positive Stemmer's sign. You can get a buffalo hump at the top of the foot, which is where swelling likes to collect. You might not be able to see the ankle contours or the malleoli of the ankle. And usually lymphedema is asymmetric. Cellulitis, which is just a bacterial infection of the skin, is common with lymphedema due to the excess fluid in the interstitium. And this fluid is an excellent medium for bacterial growth, which is why we see cellulitis happen often. So another picture of a more a stage 3, I would say, lymphedema. Lymphedema is rarely painful. However, you usually feel heaviness or achiness in your legs or your arms. Skin changes in lymphedema may be hyperkeratosis, which is an abnormal hardening of the skin, or papillomas, which are like a small, like wart-like growth on the skin. And the growth is just from the epidermis, and it's usually benign. And then ulcerations are not common. And unlike venous disease, the skin maintains hydration and elasticity for longer. So you can still feel some elasticity when you feel the tissue of the skin of the patient who has lymphedema. So here's a chart that goes over the difference between lymphedema and edema. So lymphedema is classified as a disease. Most of the other edemas are just symptom-based, and they're not classified as a disease, meaning they're going to resolve when the actual disease resolves. It's just a secondary thing, symptom. Lymphedema is a disease. It's chronic. Most edemas are caused by high water load in the interstitium, and a complete resolution of the edema is expected after the treatment of the underlying condition. In lymphedema, it's protein and water accumulation in the tissue spaces, eventually leading to tissue changes such as fibrosis. And we talked about the risk of cellulitis with lymphedema, whereas in regular edema, you won't have the risk of cellulitis. Okay, let's go on to talk about primary versus secondary lymphedema. So primary lymphedema is abnormal development of the lymphovascular system. So you can have aplasia, which is a lack of collectors, hypoplasia, which means insufficient number of collectors, or hyperplasia, which is an abundance of poorly formed collectors. So this can happen primarily when a person is born, or it may not appear till later in life. It could happen it could appear when you're a teenager or in your early 20s and 30s. So primary lymphedema is an actual problem with the lymphovascular system in the body. Secondary lymphedema is the most common type of lymphedema, and the #1 cause worldwide is something called filariasis. And it accounts for over 100 million cases of lymphedema worldwide. So filariasis is a parasitic infection. It's common in India and Asian countries, South America, Pacific Islands, and some parts of Africa. Victoria, can you tell me if you've ever seen filariasis or have heard of it?
I've seen one.
Okay.
But they're not common.
They're not common over there?
No.
Okay. So the next common cause and the #1 cause of upper extremity lymphedema in the U.S. is surgery and irradiation for cancer. Then we have other things can be like trauma, infection, obesity, chronic venous insufficiency, or self-induced. So this study is showing the incidence of lymphedema related to breast cancer surgery 20 years after diagnosis. So they took, quite a big number of women after 20 years after post-mastectomy, and those who had had a complete axillary dissection. And 49% of these women developed lymphedema, and about 13% had severe, 17 had moderate, and 19 had mild. So 49% is quite high. I think that number has gone down a little bit now with more recent research, but they're still working on figuring out why some people get it and why some people don't. So anatomical locations, typically we're going to see it in the extremities. There are people who get it intestinal or genital lymphedema, and then there's also your head and neck lymphedema. So let's talk about the different stages of lymphedema, and this was classified by the Foldy Clinic, which is in Germany. So stage 0 is subclinical or latency stage. Basically, the patient will have subjective reports primarily of adverse sensation, or there's no real clinical signs. It can be very long. You can have, this stage can be very, very long. Some cases don't develop lymphedema until 30 years after their surgery or cancer treatment. So stage 0 is a latency phase. Stage 1 is considered reversible. At this stage, there's no fibrotic tissue. The edema resolves when you elevate or overnight, you'll get a resolution of that edema. Then we have stage 2. This is an irreversible stage. There's fibrotic tissue present. There's protein-rich fluid in the tissues. And so that we don't see any resolving of the edema with elevation. And finally, stage 3, which is what you're seeing here in the picture. It's a massive edema and severe and chronic skin changes. So, this is, you can see here in this picture, this person has, on this unaffected side, or it's probably a lower stage of lymphedema, but you'll see this hemosiderin staining. That's from venous insufficiency. And on this side, you can see papillomas, which are those abnormal wart-like growths on the skin. And then we have a very large leg, stage 3. And you can see hardening of the tissue, the connective tissue, scar tissues there, and you see the papillomas there as well. Any questions so far on the stages?
Do you usually have anything in terms like you can say there is early stage 2 or late stage 2?
You can say mild. You can say a mild stage 2. I mean, sometimes I've said it's a mild stage 1 if they resolve quickly, or if I can see that there's pitting edema. Stage 2, you can classify it with different descriptors if you want. You can say early stage 2 or later stage 2. As long as you're consistent in your documentation, that's fine. Okay?
Okay.
Again, I have another question.
Sure.
How will you identify now any physical examination or clinical examination they can do in stage 0 to identify? Because stage 1 or stage 2 and 3, at least there are some symptoms that you can check on.
Right.
So, stage 0.
Stage 0 is there's no clinical signs that you can see. It's just mostly the patient is telling you, my arm feels really heavy, it's achy. It's more just, or you can call it stage 0 if a patient is at risk for lymphedema, if they've had surgery, if they've had lymph nodes removed. You can't see any swelling. There's no measurable difference in their arms, but they're still in a latency phase if they're susceptible to getting lymphedema. Does that answer your question?
Yeah, that does. So at that time, is there any maybe from the history of the patient as he or she tells you how he's feeling or she's feeling? So from there, that's enough for you to start taking some kind of precautionary measures so that it doesn't kind of progress to the next stage.
Yes, for sure. There are cases where if somebody is saying, I feel heaviness or achiness in my arm, and there's absolutely nothing you see clinically, then you can definitely take preventative measures. You could put them in a very light compression, like 15 to 20 millimeters of mercury compression garment. If they really feel like it might start swelling, you could do that. I wouldn't do any compressive bandaging or anything, but you could just mostly educate them on, you know, this is what you need to do. You would tell them to basically watch for the swelling, make sure that they can tell the difference in their skin if they start seeing skin changes. So we'll go over patient education and preventative things that you can do. You would talk to them about exercise and how to prevent lymphedema from happening. So those are all the things that you can do in the latency stage. For sure you want to address it. And there are some places that, you know, they will talk to the patient prior to their surgery and have an appointment where you will give them a lot of information and tell them to watch for swelling and make sure that they do all the right things. They don't do a lot of heavy lifting. They're not sitting in a lot of heat, because heat can stimulate the lymphedema to occur. So a lot of the education you would do prior to, you know, any clinical signs that you see. Does that answer your question?
Thank you.
Yeah, okay. So let's talk about diagnosis. So basically, lymphedema is diagnosed by excluding other edemas. So the most important element is going to be your physical exam, your clinical diagnosis through the history and the examination of the patient. There are other ways that people do diagnose lymphedema. Bioimpedance measures the amount of extracellular fluid within a limb by passing a low-frequency current through the tissues and measuring resistance. This measure provides a comparison between the edematous limb and the unaffected side. Pyrometry, that's infrared light to scan the image of the limb, thereby measuring the volume of the limb. It measures every 3 millimeters and is very sensitive to volume change. Then we have something called lymph scintigraphies. And that was one of the pictures that we saw earlier. Is a lymphatic function test which shows the quantity of fluid processed by the lymph capillaries and collectors. This test is used in cases where the diagnosis of lymphedema is uncertain. However, in medically uncomplicated lymphedema, the results of the test have no bearing on the treatment protocol. Then we have ultrasound, CT scans, MRIs. Those are used to rule out other conditions or DVTs, cancers. And then they used to do something called lymphography, but they don't do that anymore because some people had died from the shock of the dye that they were using. Did we have somebody join? Fatuma? I think Fatuma joined, but I don't know if we can hear her. Okay.
And Victoria, who's at your site with you there in Nairobi? Who's on the phone with us?
Pardon?
Salima, it's Abraham, are you there as well as Caroline?
Yes, yeah.
Okay.
Yeah.
Okay, great. Salima?
And Caroline?
Caroline, yes.
Yes, I'm here.
Perfect. Thank you.
Okay. Okay, so now we'll talk about...
Firstly, I have a question on the measurements.
Sure.
Apart from using the tape measure, is there something else which can be used to measure, maybe like the volume, to know the volume of the fluid?
Okay, so yeah, that's a great question. So actually, we use the measurements from the tape measure, and there's a formula to get the volume. That's how we do it. So you have to take the measurements every 4 centimeters, and there's a formula that you use to, and basically it's made into an Excel spreadsheet, and the formula is in the spreadsheet. So I can forward you the link for that calculation. And basically, we have an Excel spreadsheet that you have on your that you put your measurements into, and that will calculate your volume for you.
Okay. That would be great.
Okay, great. So differential diagnosis. So now we're talking about a few other things that appear as edema that you want to make sure that this patient doesn't have when you're trying to decide. Okay, so let's talk about a few of these. So the first thing is lymphedema. So lymphedema, it's a primarily a condition of abnormal adipose tissue. So there's fat cells that are overly produced in the body, and it's not primarily fluid, it's primarily fat tissue. Sometimes you also have lymphedema that coexists with lipedema, and often this condition is confused with obesity. But the distinguishing feature is that their upper body is disproportionate. So meaning they might have a really small upper body and then their legs are very big. So that's very unusual with obesity. Usually in obesity you have more proportional obesity. So their lower body is what's going to be bigger. So you're going to see bilateral symmetrical swelling from the iliac crest to the ankles, and usually the feet are not involved in this. So Stemmer's sign, which is the sign where you pick up the tissue on the second toe, that's negative, meaning you can pick the tissue up. And there's little or no pitting in this, and you don't often see cellulitis. What you usually see is that they're very sensitive or painful to palpation, and they can bruise easily. So another thing that it might be could be venous edema. So if you have someone with CVI or venous valve failure, the high pressures in the veins produces increased capillary pressure, resulting in progressive edema and gradual leaching of blood products into the skin. And that's when you see that hemosiderin staining. So you're going to see this browny red stain in the skin, and that's from the blood seeping out of the capillaries. You still get over a long period of time, you still will get fibrosis of the subcutaneous tissues, leading to atrophic skin and frequent ulcerations. Okay, the swelling could be from an acute DVT. So acute DVT thrombosis, typically you have a sudden onset. It's usually on one side. It's painful. You can get like a blue tinge. You have a positive Homan sign, which is when you grab the calf and they feel a lot of pain. It could be very lethal. You could get a pulmonary, that thrombosis can travel up to the lungs and you can have a pulmonary embolism. So typically if you have these signs and you're suspecting a DVT, then you would want them to get a Doppler ultrasound right away. Congestive heart failure. So one of the things that the edema could be coming from would be CHF. So in this kind of edema, they have more edema distally, and they have a lot of pitting edema, and it's always bilateral. And then when the person lies down or elevates, that edema is going to resolve. So that would be the difference if you saw a later stage of lymphedema. That would not happen. Usually there's no pain. You might see shortness of breath. You might see jugular venous distension. And the way to diagnose this is they're going to have a chest x-ray, a cardiac echo, and their physical exam with their cardiologist. Malignant lymphedema, like you see in this picture, you're going to get more proximal onset, rapid development, continuous swelling and nodules, and it's more hematoma-like discoloration, non-healing wounds, recurrent malignancy. So this is more of a specific type of lymphedema. MYXEDEMA is it's various dysfunctions within the thyroid gland. It's a special form of muconoid dermopathy which is caused by fluid accumulation associated with increased proteoglycans. So this is due to a thyroid dysfunction, and it's called MYXEDEMA. Dry skin, brittle nails, thinning hair, decreased sweat, and orange-colored skin is what you're going to see, along with abnormal thyroid tests. Complex regional pain syndrome, you might have seen this. They're going to feel like they're warm, red, burning, edema, so they're very painful. They might feel coolness or kind of like a mottling or like a matting of the skin, bluing, brawny edema. Again, the dry, brittle nails. So this is more, someone might have osteoporosis. So you're seeing more atrophy of the skin. So it's slightly different symptoms than lymphedema. So any questions on any of those other conditions that I just discussed before we go into treatment? No? Okay, good. Okay, so here are the treatments for lymphedema. So there's different things that we're going to talk about, CDT, compression pumps, surgery, compression garments, medications. Let's start with CDT. So CDT, complete decongestive therapy, is the most successful treatment for lymphedema.
Yeah, your slide hasn't changed.
Really? I can see it.
Okay, well, we can't.
Oh, wow. How about now?
It's still on CRPS.
Oh, okay.
Nairobi, what slide are you seeing?
Sorry?
Which slide are you seeing on the screen?
Complete decongestive therapy, that's what is being seen.
Oh, great. Okay. I have to get back to that now. Okay. Salima? Uh-oh. I have to go through the whole thing again. Just 1 second, I'll just catch up. How about now? Salima, what do you see? Are you seeing me change?
I'm still on complex regional. I don't know what they're on.
Okay. Victoria, can you see the complete decongestive therapy slide?
Not yet. Right now, it's the incidence which is showing. Okay, there it is. That's fine.
Okay. So, what is CDT? So there's 5 different things that consist of CDT. You have your manual lymph drainage, you have compression bandaging, exercise, skin and nail care, and instruction and self-care. I'm just trying to see who's joining us. Looks like Fatuma is still with us. Okay, good. Okay, so manual lymph drainage. So here, this is why the benefits of manual lymph drainage. It increases lymph vessel contraction, increases resorption of the protein-rich fluid. It redirects the fluid around the blocked areas. This is very important, and it promotes relaxation and has an analgesic effect. So manual lymph drainage is, a huge part of this. This is where we come in. This is a big thing that we do for the patient. And I've seen cases where, the patient walks in, we measure them, you do the manual lymph drainage, and you can already feel a difference in the skin quality, in the amount of fluid that they have in their limb just after doing the manual lymph drainage for, 45 to 60 minutes. So how are we redirecting the fluid? So if you look at the upper extremity, so you have, and this is the upper extremity is affected. So we're trying to put, if the patient has a scar here from a mastectomy, you're going to try and push the fluid up into the neck or across into the other axillary lymph nodes. Or we're going to try and push the fluid down into the same side inguinal lymph nodes. Okay, so that's for the upper extremity. For the lower extremity, if we have a incision over here and that's why the fluid is getting blocked, then we want to redirect the fluid up onto the same side axillary lymph nodes. We want to redirect the fluid into the abdomen or to the opposite side into the opposite inguinal lymph nodes. Okay. The next thing that you do in CDT is compression bandaging. And this is a picture that shows compression bandaging using foam, and we'll talk about that a little bit later. And then this is a picture of what it looks like when it's completely finished, when the bandaging is completely finished. Okay, so why do we do bandaging? Bandaging is really important because it reduces the filtration rate. It improves the efficiency of the muscle and joint pumps. It prevents reaccumulation of evacuated edema fluid, and it breaks down deposits of indurated tissue. So basically, once you've done your MLD, your manual lymph drainage, you've now taken the fluid out of that limb and you've reduced the filtration rate. Now you want to put the bandages on so that the swelling doesn't come back. And also the type of bandages that we're using are called short stretch bandages, and they have a high working pressure, which means that when the muscles and the joints are working, the bandages put a pressure against the skin, and that allows for these muscle and joint pumps to push fluid out of that area. So by doing this, you're going to stop the fluid from coming back into the limb, and also the bandages will help to break down all that fibrosis or that extra tissue that's in the skin. Okay, so the next thing we talk about in CDT is exercise. So we're going to do exercises with the compression bandages or the garments on. And again, this is going to improve their range of motion, their strength. It's going to help them to increase the joint and muscle pumps, which while the bandages are on, so that you can help to get fluid to come out of those tissues. So the type of exercise that you want to do is low exertion, slow, rhythmic exercise. We want to tell the patient to do a lot of deep diaphragmatic breathing. You want to tell them to do a lot of walking with their bandages on. And this is really important to educate the patient on during, between your sessions, or even having them do it in the clinic. Okay, so it's important to, have the patient take care of their skin and their nails. It decreases the risk of infection. You want to keep the skin very clean and avoid any injuries, any bites or burns to the skin, because basically any break in the skin can increase the risk of infection. And you want to use, clean all the injuries, use topical antibiotics if they see any cuts in their skin. And if they see an infection, if they start seeing any of the signs of cellulitis, then they want to call their physician right away, because they will need to get onto antibiotics. And you won't be able to do any more of your lymphedema therapy if they have a cellulitis that's untreated. They need to get treated right away for any cellulitis. The other thing that you want to tell your patients, if they have their nails done, is never to have their cuticles cut or trimmed, because the cuticles can start bleeding and they can get an infection from that. Instructions in self-care. So we're educating the patient on skin and nail care, how to prevent infections. We're going to teach the patient how to do their own bandaging, once they have compression garments, how they need to put the garments on and off. We're going to give them exercises to do. We're going to teach them how to do self-MLD, so self-manual lymph drainage, and we'll talk about that during our training. And you know, you're gonna check up on these patients frequently or periodically if they're doing really well. So infections. Cellulitis, like I said, is very common skin infection with patients with lymphedema. It's because they have all that extra fluid, it's a really, really good medium for bacterial growth in the skin. So the patient needs to be able to recognize the signs of infection. So you need to be asking your patients, what are the signs of infection? What are you going to do if you see redness or warmth, swelling, achiness, pain, if they're feeling fluish, if they have a fever and they're not feeling well? Those are all signs of an acute infection or cellulitis. So like I said, we're going to not do MLD until they're cleared by their doctor. Typically, if they're on antibiotics for maybe 2 or 3 days, they can start having MLD again. So very important. And then we'll talk about, you know, CDT or complete decongestive therapy is a 2-phase treatment. So you're going to have your intensive phase, which is when you're going to do daily treatments. And it's done by, you know, your lymphedema therapist. And the duration of the treatment depends on how severe the lymphedema is and the way the patient is responding to treatment. So typically you'll see treatment in this phase lasting 3 to 4 weeks, where they'll be getting lots and lots of physiotherapy treatments. And then we go into the second phase, which is more of a self-care phase. So remember, we talked about lymphedema being a chronic disease. So the patient needs to realize that just because they stop coming to therapy doesn't mean that their lymphedema is gone. It's a chronic disease. It can be managed, but it can also come back right away. It can come back with, you know, something small like a cut in their skin, and all of a sudden their lymphatic system won't be able to handle the load, and they'll be back to, you know, a flare-up. So in the second phase, we're going to, you know, have them wear garments during the day. They might have to do bandaging on their own at night. They're going to have to do exercises daily. We're going to, you know, talk again about making sure they take care of their skin and their nails, and do follow-up visits for manual lymph drainage if they need to. So why are we doing CDT? The whole goal of doing CDT is we want to reduce the fluid, we want to reduce the fibrosis in the tissue, we want to restore mobility in the patient, prevent the infections from happening, make the patient look better, feel better, improve their quality of life, and make them as independent as possible. So CDT is not a cure. Like I said, it's a chronic disease. It's good because it's non-invasive, it's highly effective, and it gives the patient a measure of control. You know, they feel like they can manage this. Once they've done some CDT, they can manage their lymphedema. They're on the self-care phase. They can wear garments and take care of the lymphedema on their own. But it does not cure the lymphedema. The lymphedema is chronic. And the patient needs to understand right from the beginning that this is we're going to help them get better, reduce their volume, but it's not going to be gone forever. So when does CDT not work? There are some conditions where CDT will not work. If they have a malignant lymphedema, if there's a cancerous lymphedema, if the MLD is done poorly, if the bandages are put on not properly, and if you know they're not doing the proper CDT protocol, it could be due to other illnesses, patient compliance, or maybe the patient really doesn't have lymphedema. This is when you'll see that CDT will not work. So this is a study that shows, you know, there was a study shown on the efficacy of CDT. So they had a large population, about 300 patients, 149 upper extremity, 150 lower extremity, so about half and half. And during phase 1, they did about 15.7 days of CDT. And the results were really good. They had 59.1% of reduction in volume for the upper extremity and 67% in the lower extremity. And they reduced their infections from 1.1 per year per patient to 0.65. And after 9 months, 86% maintained their initial reduction. So it shows that, you know, this is a very, very effective form of treatment for CDT, for lymphedema. This is another study that was done in 1997. A smaller sample size, 56 had upper extremity, one arm, and 38 had one leg lymphedema. And the results were 62% upper extremity reduction and 68% in the lower extremity of volume reduction. After 36 months, they were able to maintain about 60% of their volume reduction. Okay, any questions so far about what we've talked about with CDT before we talk about garments?
My question will be, in case you get a patient who has venous edema,
okay,
what is the management protocol?
Okay, that's a really good question. And in fact, the CDT works really well on chronic venous insufficiency patients. So even though it's not caused by the lymphedema, you can still, the bandaging, the compression bandaging is very, very effective. And this is something that we need to educate the vascular clinics because they see a lot of patients. Basically what happens is when you get the edema from the venous system failing, you still have changes in the tissue. It might not be protein rich fluid, but there's still fluid. And the compression bandaging really, really can reduce their volume. So a lot of these patients in the vascular clinic, they'll put them in garments right away. But it will maintain their volume, but it won't reduce the volume. So sometimes by educating the doctor and saying, look, we can reduce the volume by doing the bandages first, and then we'll put them into the garments after they've reduced the size. But compression bandaging is the #1 thing you can do for the venous edema.
Okay.
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 And if you do have patients, who are coming from the vascular clinic, that's really good. Once we go over the bandaging techniques and you learn to do that, you can try it on them and, show the doctors that they're making really good progress. Because basically you want to get them into a garment at their lowest size. Sure, garments will work to maintain, and they will give compression, but the best thing, the most effective thing to do is the MLD and then the bandaging for the intense phase, the first phase of CDT. And then once they have reduced their size as much as possible, then we want to put them into the right garment.
Okay.
Okay. So let's talk a little bit about compression garments. So these are essential, like I said, after we've done the decongestive treatment.
Okay, allow me to interrupt.
Yes?
Okay, regarding still about venous edema, what about if the patient has got sensitive skin and maybe there is kind of cellulitis which is already forming, and how will you go about it now? Because I think if you go ahead with the compression bandaging and there's already the wound and the skin is sensitive.
Okay, so you're talking about sensitive skin and wounds on the skin?
Yeah, either the wounds coming out and the skin itself is also very sensitive.
Okay, so both of those you can still do the bandaging. Basically for the wounds, like you'll see a big change in the wound actually if you do the bandaging. So what you would do is put a pad, just like a wound care pad, ABD pad on the wound, and you would do the bandaging, and you'll notice, because typically the bandages will be on for 1 day or maximum 2-3 days, but if they have a wound, I would have them come back the next day, and you're actually going to see that the wound is going to get better quicker when they do the bandaging, because you're not getting all that extra fluid that's causing that wound to stay open. You're actually getting better healing. And sensitive skin, same thing. We talked about lymphedema, where the abnormal fat accumulation in the tissues, that makes this, usually those patients have very, very sensitive skin because of their condition. And the compression bandaging really helps reduce the sensitivity in the skin. So I don't know, I'm not sure. I mean, it works really well. I'm not sure how to explain it, but the sensitivity of the skin with the bandaging, the patient feels a lot better once the bandaging is over. The skin is less sensitive as they continue to do the bandaging. The bandaging isn't, it's very comfortable. And when I come there and we do the bandaging on each other, you're going to feel that if you do the bandaging correctly, it's very comfortable. It doesn't hurt. It's not painful. It actually feels very comfortable. And especially these patients who have this heavy, aching, sensitive skin, they actually feel very comfortable in their bandages. Does that answer your question, Abraham?
Thank you.
Thank you.
Okay.
Yes, please.
Okay. Fatuma, do you have any questions? You can text me if you have any questions. I know I can't hear you, but I know you're on and that you can hear me. So if you have any questions, just text them, okay? Okay, so let's talk about compression garments. So compression garments obviously are very, very important. Once you've done all your hard work with the manual lymph drainage and the bandaging, you want to make sure that this patient gets into the proper sized garment. And there's different types of garments. You can get custom made ones. You can get ready to wear garments. And I'm gonna bring some garments with me to show you guys. Victoria, if you have some samples on hand for those people who haven't seen the garments, it would be great to have some different samples. But basically, which garment company are you using mostly right now?
Right now we're using the circular knit.
Circular knit, and which company is it?
From MYXEDEMA.
MYXEDEMA. Okay. So so the circular knit garments, those are ready to wear. So they're ready. They've made them in different sizes. And so typically, are you measuring the patients and then you order the size, or you have different sizes in stock?
We have different sizes in stock. We measure and then fit.
And sorry, what did you say?
I've said we have different sizes in stock.
Yeah.
So once the patient comes, we take the measurements and then do the fitting.
Okay. Yeah, so there's many different companies. The flat knit compression garments, those are actually custom made. They're made in Germany, usually. There's different vendors that make them. Medi, I'm pretty sure, makes a custom knit. The one that we use mostly is either through Solaris or a company called Jobst or BSN. I texted you about BSN, Victoria. So BSN is a company that makes a garment called Elvarex. Obviously, they're quite pricey. I can get an idea of the price list for you, but these garments, the reason that you get a custom made garment would be because it's going to obviously fit the patient much better, exactly to their measurement. You can make the garment specific. So let's say their calf is very swollen, but their thigh just has mild swelling. You can custom do the compression, so you can make a larger compression for the area that's more swollen, and you can do a lighter compression elsewhere. The flat knit garment is just the way they make it is just a better containment, which is why it works better. But you know, we still do well with the circular net. The biggest thing is picking the right compression and doing the fitting properly. So that's just something that we'll talk about as we go along, making sure, like this patient, you can see in this garment right here has little folds here in the elbow. You know, you want to make sure there's no creases, no folds, because you don't ever want the lymphatic system to get cut off anywhere where it's trying to drain. So those are really, really important things to look for. Even a lot of times you'll see at the top of the garment, there'll be, if you take it off, you'll see a very big dent in the skin, and you never want to see that. You don't want to see like a tourniquet effect in the top of the garment, because we don't want it. We want the fluid to go all the way back up into their neck and into these into the lymph nodes if the lymph nodes are working. And so you never want them to get cut off. And remember that the lymphatic system is sitting right under the skin. So we want to compress it, but we don't want to cause too much indentation where those lymphatics are getting pressed and they're not allowing the flow to occur. Okay, any questions on garments? Anybody have any questions? Okay, so let's talk about medications. So there are medications sometimes that you'll use, that the patient will be using during lymphedema management. We talked earlier about antibiotics. So, you know, topical antibiotics, if the patient has a little skin cut and you want to make sure that they don't get an infection. Systemic antibiotics, those are prescribed by the doctor. Usually, if they have a cellulitis or another infection happening, usually the patient is not on routine antibiotics to prevent any infection, but it's possible if they're having recurrent cellulitis that their doctor will have them on prophylactic antibiotics. Diuretics, usually you'll have diuretics if they have any comorbidities. This will increase the interstitial osmotic pressure, and it'll increase the edema. So you want to make sure that if they're taking diuretics, that there's a reason they're taking it, because lymphedema, it might be more resistant to treatment if the patient is on diuretics and they don't need to be. Compression pumps. So traditionally, the pneumatic compression pumps, it's controversial to use the traditional pumps. Some of the studies are demonstrating improvements in the patient's condition, but other studies are showing that they're getting actually some proximal or genital swelling from doing the traditional pumps. If you look at this picture on the bottom, this is a FlexiTouch. And the way this compression system works is it's kind of simulating the MLD, the manual lymph drainage that we do in therapy. So basically the way it works is it doesn't, if their limb is, if let's say this upper extremity is what they're trying to, is the swollen limb, this system will do the arm last. So first it'll go through a whole half-an-hour program of doing drainage in all the other areas, in your abdomen, in the inguinal nodes on the same side. It very much mimics the MLD that we do. And then towards the end of the treatment, then it's going to start working from the upper extremity. It's going to clear the top, then work its way down, and then it's going to work back up and back through the whole body. So this FlexiTouch system is designed better. I'm not sure if it's available over there, but just so you're aware that it is something that's better than the traditional pumps that we've been using. Victoria, can you tell me a little bit about the pump that you have?
Yes, it's actually the pneumatic compression pump.
Okay.
And we have been using it, and of course, what I've realized is that it is best used to loosen up the tissues, and then after using it, then I do the manual drainage.
Oh, so you use it first and then you do it. Okay.
Yes.
So the manual lymph drainage, if you're doing that after, so if you are going to continue to use the pumps, the important thing is that when you do the MLD sequence, that you make sure that that fluid that might have come out of the limbs is being directed into the proper areas. And we'll go over, where you should be directing that fluid so that the patient isn't getting any genital swelling, or that swelling isn't it's coming out of the limbs, but it's not staying in other areas, in other proximal areas. And doing the proper abdominal exercises so that the patient is able to clear that fluid and it goes back into the neck, into the venous angles, back into the blood circulation. Okay, so surgery. Sometimes lymph vessel transplantation or lymphovenous anastomosis surgeries are they're microsurgical approaches to restore inadequate lymphatic system, except that these procedures are quite complicated and most patients are not eligible for this surgery. You can get debulking surgeries, are also referred to, so they're doing reduction in large amounts of the subcutaneous tissue. They usually result in scar tissue, and most cases are cosmetically not acceptable. So sometimes, you'll get removal of skin folds after you do successful decongestive therapy. If there's a lot of excess skin hanging, the patient might get some surgery to remove the skin folds. But typically, these surgeries aren't very, they're just not very effective, so they're not done too much. So now we'll just take a look at some diagrams of patients before and after. This is after 4 weeks of doing CDT. So this is, you see this limb before and after, you see a reduction there. This patient, a little more reduction you see. This is after 4 weeks of doing daily treatments of CDT. Another one 4 weeks after. So this is after doing phase 1, and the patient has reduced their size, and now we can go on and put them into a compression garment. You can see the difference in the dorsum of the hand, where a lot of the swelling, the bandaging works really well because we bandage them all the way from the fingers up. And so this dorsum of the hand you're not allowing that reaccumulation of fluid, and you can see here how much better her hand looks. For the lower extremities, this patient, the treatment was done after a 3-month period. So this was 49 treatments of CDT. This patient, it was done after 6 weeks of daily CDT. So 6 weeks, not very long time, but obviously the patient is going to have much more function, much more better cosmetically and better quality of life. Okay, so that's the end of my presentation. Do you guys have any questions, concerns? Is there so our next two topics we're going to cover a little more detail of the anatomy and physiology. Are you comfortable with that, or is that something that you want a little more knowledge on lymphedema?
I think we're comfortable with that.
You're comfortable with the anatomy and the physiology? So maybe,
Sure.
yeah, we'll go over a little bit more in detail next time on how the manual lymph drainage, I can show you some videos on how they're done and how the measuring is done. And then when I come there in November, we can obviously practice all of that. I'm trying to get some bandages for us so that we can be practicing the bandaging as well.
Good.
Okay.
Yeah, sure.
Fazia, just to go over, so the dates, if we want to share with the group, the course will be offered, right?
Yes. So we'll be coming there, and the training will be happening from November 16th through the 20th. Or no, sorry, 16th through the 19th or 20th. We'll see how much time we have. Victoria, are you going to be able to? You have some patients that you think you can have come in?
Yes, I have patients who can come in. We only need to agree on the dates which I need to call in the patients.
Okay, so you can tell them it's probably going to be the Thursday of that week. So I think that's the 19th. Yeah. Okay. And so we'd like to invite one therapist from each of the other Aga Khan hospitals to come and join the training. So we'll be coordinating that, and hopefully we'll have one therapist come from every center to learn the CDT and to come together and just work on lymphedema therapy. And obviously, we'll be learning from you as well. You've had some experience with this, so whatever you can bring to the table, we'll be happy to learn. And things might be we're hoping to be able to set up some resources locally so that you can get the products that you need quickly and efficiently. So we'll continue to work on that. If I can get in touch with the BSN vendor in Kenya, perhaps we'll have them come stop by while we're there so that they can show us some of their products.
And the other piece is most of you should have received in your WhatsApp a SurveyMonkey survey regarding this course. Have you all received it?
Yes, in Nairobi we have received and responded.
Okay, great. Fatma, and even Kisumu, all of you, if you could check, and if there's other people participating, it can actually be per participant. So Victoria, if you answered just one on behalf of all three people, but three people have different levels of competencies, you can put in more than one. You know what I mean?
Yes.
Yeah, so if we can make sure that everybody responds and sends those surveys in, that would be very helpful to our cause.
Wonderful. Yeah, go ahead.
Yeah, if there's other therapists that you're working with and we need to add them on, please add them to the WhatsApp lymphedema group.
Abraham?
I know Carol is not in the group, but she will send, we will send you her contact so that you add her in the group.
Excellent, thank you.
Who was that? That was Caroline, for Caroline?
Caroline is one of the therapists in Nairobi.
Yeah, did you say you're going to send her contact information?
Yeah, we'll send her contact because she has not been added in the lymphedema group.
I see. Okay, wonderful. Thank you. Okay,
Thank you.
If nobody has any more questions, then we can end this session. And I think our next one is on next Thursday, the 22nd.
Yes.
Okay, and you guys doing okay with your audits? Everything's going well?
Everything is going on well. We are still organizing on the logistics. We'll keep updating you. Okay,
wonderful. Okay, thank you so much. Victoria, if Suleiman ever would like to join our webinars, he's more than welcome to join us. We'd love to hear from him as well.
Thank you.
Okay, thank you. Have a good day, everybody.
You too. Bye.
Bye-bye.
Bye.